You're listening to Treating Blood Cancers, the LLS podcast series for professionals. We will be joined by cancer experts to discuss blood cancer diagnosis, treatment, side effects management, and the importance of clinical trials. They will share their experience in treating patients and discuss strategies for optimal patient care. Let's get the conversation started.
Welcome to Treating Blood Cancers, the LLS podcast series for professionals. I'm Dr. Ken Miller. I'm a medical oncologist, a hematologist, and an LLS volunteer. I want to thank all of you so much for joining us on this episode. And today we're going to be discussing complex cases in myeloma and amyloidosis, focusing on challenging diagnosis, treatment decisions, and patient management. We're delighted to be joined by Dr. Angela Dispenzieri, who's a consultant in the Division of Hematology and is a Serene M. and Francis C. Durling Professor of Medicine and Laboratory Medicine and Pathology at Mayo Clinic in Rochester, Minnesota. Angela, thanks for joining us.
Well, thanks for having me.
So I have to say, I have been looking forward to talking today because I really want to ask about amyloid. And I want to start with an admission. And the admission would be, in my career, which has been for a lot of years already, I have made the diagnosis of amyloidosis only a few times. And I have a feeling that I have missed some cases. What are some of the reasons why oncologists, hematologists like myself may not recognize it? And along those lines, what are the things that would give us as clues and hints to bring to our everyday work?
Yeah, you wouldn't be alone in potentially missing cases. Amyloid is a great imitator and it's less common. It's about a fifth as common as myeloma, and myeloma is not that common. And so to be a general oncologist or hematologist, it's a lot to take in. But there are definite differences between the diseases, and I think that there are clues if you're sort of taking the time and being discerning to differentiate the two. And before I say how one does that, I think the importance of doing that and making the difference is that the therapies are different. We use quad therapy for both diseases. As you know, the standard for myeloma these days in the younger population, maybe the older population, is a CD38 antibody like either daratumumab or isatuximab, along with lenalidomide, along with bortezomib and dexamethasone. And so that's like the initial therapy for myeloma. But the quad therapy for AL amyloid is actually everything but the Revlimid, everything but the lenalidomide, and it's Cytoxan instead. And the reason for that is that patients with AL amyloid don't really tolerate the lenalidomide as well. And if you do use lenalidomide, the 25 milligram standard dose that we use in myeloma without even thinking twice can be really quite toxic in these patients. And if you use it in relapsed amyloid, you typically don't start with more than 15 milligrams. And if you do perhaps miss the diagnosis up front of AL amyloid in a patient who has a plasma cell disorder and you just call it myeloma alone, if you are using lenalidomide-based therapy and you find that your patient is having a lot more toxicity than you would have expected, lightheadedness, extreme fatigue, even maybe some shortness of breath, the bells might go off a little bit, showing that maybe there's something superimposed here. But hopefully we can make the diagnosis before we choose our quad. And so what are those clues? I think that one of the biggest clues is an amount of fatigue that is out of proportion to the CRAB features. So, myeloma patients are typically not very tired per se, unless they have tons of pain and they're on a lot of narcotics, or they have severe anemia, or they have hypercalcemia that's significant, or significant renal failure. In general, they're not going to feel great, but they're not going to be talking about just a massive fatigue if they don't have those extreme abnormal values. Whereas an amyloid patient may not be very anemic, but will have fatigue, and that might be due to cardiomyopathy that's unrecognized. And so fatigue that would be out of proportion to the myeloma features that the patient is exhibiting is one. Another thing is if you're looking for proteinuria, and if they have significant proteinuria, but most of it's albumin and not M-spike, you really need to take a hard look and think, is this amyloid? Because again, myeloma patients will more often, they could have 5 grams of urinary protein per 24 hours, but the vast majority of that is going to be light chain, M spike. Whereas in an AL patient, they could have 5 grams, but maybe just immunofix positive, but it's all just non-specific proteinuria. So that would be like another type of a clue. An elevation in alkaline phosphatase would be another clue that your patient may have amyloid as well. It's unusual for myeloma patients to have high alk phos, even if they have bone disease at the get-go. And then if you have the time and the energy to sort of be doing an amyloid review of systems, it's very easy for me to be thinking of it all the time because I'm a plasma cell person. And so all these things are just my everyday moment. But when you do have a busy practice, you can't be thinking of everything all the time. But things like, is the patient having edema for no reason? Or they have weird pinch purpura on their face, orthostasis, paresthesias, things like a little bit of macroglossia, jaw claudication. On exam, if they have hepatomegaly, again, anything like the other signs I already told you, the alk phos, the nephrotic syndrome, are also things to think about. It's interesting. So ASH has these guidelines now, and there was a panel for the diagnosis of AL amyloid. How do you go about it? And there was a bitter debate as to whether all bone marrows for patients with myeloma or smoldering myeloma should have a Congo red done just automatically, yes or no. And I was sort of in the no camp because the sensitivity is really only about 50-55%. And in my practice, at least, I think a really good review of systems is helpful. And you don't want that false assurance either, because when a sensitivity isn't so great, oh, no amyloid done, but it's not that simple. But sometimes that is a worthwhile thing to do. And I think each practice has to decide how they want to play that.
So I have to tell you, I wrote all that down. This was a wonderful review, and it makes me think of one patient in particular I'm seeing now. I'd love to hear your experience. We'll call it a complex case, but a patient with both diseases. Tell us a little bit about a patient like that from your practice and making the diagnosis and treatment.
Yeah. So more often than not, once they have amyloid, they're mostly amyloid. And what I mean by that is, yes, half of patients with amyloid will have more than 10% bone marrow plasma cells. So they meet criteria, more than 10% plasma cells, that's myeloma. But more often, they will not have typical CRAB features. It's unusual. Maybe 10-15% will have actual bone lesions or actual significant anemia. And again, most amyloid patients will just have really significant nephrotic syndrome rather than a reduced EGFR. And so typically when I see amyloid, I'm all over it's amyloid, because the problem with amyloid is that these patients on average have a less sick bone marrow but a more sick body. Whereas a myeloma patient has a very sick bone marrow with not such a sick body sometimes. Okay, they have some bone disease, maybe a little renal insufficiency, but with our highly effective therapies, usually you can reverse that. And, if they have the hypercalcemia and stuff. So amyloid goes to the top if they have both diseases. And then I will typically use treatment strategies. Again, the daratumumab, cyclophosphamide, bortezomib, and dex, dara-CyBorD, dara-VCD, however you want to phrase it. That's the Andromeda trial that really showed over 90% response rates, 60% CR rates in patients with AL amyloid. I mean, they excluded patients with overt bone disease, but again, that's such a minority, it doesn't matter. But they could have significant plasmacytosis, and they can do remarkably well. Now, the one difference I would say is that in patients who do have much more myeloma-like features, they really do have a lot of plasma cells. Again, remember, median percent plasma cells in patients with AL is 10%. So they're patients whose bone marrows look like MGUS, right? It's 5% plasma cells, but yet they can be very sick because amyloid, it's the immunoglobulin light chain that's misfolding and depositing in the heart or the kidneys or the liver or all three or the nerves, and they have autonomic dysfunction, or they may have peripheral neuropathy. And so each of these things really color what goes on for that patient. So if they do have a higher bone marrow plasmacytosis, I might lean a little harder on transplant. Nowadays, with the Daracibor-D, we're doing fewer stem cell transplants in these patients because they get complete hematologic responses. And if you can get a complete hematologic response over the course of the next year or two, you can expect an organ response in these AL patients. And so there's less reason to do a transplant. That said, if a patient has really more myeloma type features and they have maybe bad cytogenetics, deletion 17p, plus 1q, amplification, if they have those features, perhaps I would encourage transplant a little bit more in that setting.
Are the risk factors, the profile that we get, the same in both diseases?
So the important stuff in amyloid is really about the heart. It's interesting for amyloid patients because when you look at survival curves, there's the first drop off. And again, in the first year, 6 to 12 months, what you can see is there can be about a 40% death rate just there. And that's all about the heart, because if these patients have significant cardiomyopathy related to the amyloid in their heart, even though you might give them excellent plasma cell directed therapy and even get them in a CR, the horse is out of the barn and bad things can happen. But once you get past that first 6 to 12 months, or if they didn't have very significant heart involvement, then really the thing that is important is how easy is it to kill their clone. And so the ultimate thing initially is what is the troponin, what is the NT-proBNP, because these are the heart markers. And then when you get past that first year, then, how high was the light chain, the plasma cells, and there are various staging systems that are used that sort of incorporate those features to give you a risk. But the key is early diagnosis, if you can do it, is number one. And then the second part is getting a deep hematologic response so you can basically stop further organ damage and then also allow for organ healing.
So I have to say, this is a golden opportunity for me because I'm thinking about some patients that I'm seeing. The first is a man that I took over from another hematologist who retired, but he's 80 years old. He had a small bowel obstruction and was found to have actually multiple amyloidomas in both the large and the small intestine. So they resected one, they had reanastomosed. He was diagnosed with this. He was treated initially with an induction regimen. It was probably RVD a number of years ago. He still has a small gammopathy. He does not have any more amyloidomas, at least when scoped and on an MRI enterography. But here's my question. What I've been doing is essentially treating him with Revlimid at a low dose for a period of time until the spike goes away, and then a little bit longer, and then trying to stop it, because otherwise I think he'll be on Revlimid for too long a period of time. Is there too long to be on Revlimid? What are the things you would worry about? And what are some other alternatives? And what would you suggest?
Okay, so that's a really interesting case that you just shared. And so, as you were talking initially, when you have amyloidomas, more times than not, those tend to be a form of localized amyloid as opposed to systemic amyloid. So when you have localized amyloid, you typically won't have an M protein associated with it. Sometimes there is enough mass, tumor burden, so to speak, that you can get a circulating monoclonal protein. I would also, before I answer your question in full, did the patient have a bone marrow that had plasma cells, or was it just the amyloidomas in the gut?
Yeah, he did. I think it was a small
Yeah.
population,
Okay.
probably, yeah,
All
5
right.
to 10%.
Okay. Because if he didn't, that is kind of a localized entity. And if it was something where he had bowel obstruction and they cut out the amyloidoma or whatever, I would just watch him and do nothing else, because that is a localized sort of entity. Because more often than not, patients with amyloid don't get masses. It's really this infiltrative type of process of the immunoglobulin light chain rather than real big tumors. But in your instance of this gentleman who has really systemic amyloid with bone marrow involvement, circulating immunoglobulin, presumably elevated immunoglobulin free light chains, Has he ever shown organ involvement, I guess is my next
No,
question. So his heart and kidneys, or, other than the gut and the local mechanical problem.
well, okay, actually, this is part two.
Okay.
Uh, Very good questions. No cardiac involvement. And I looked initially when I saw him. However, the second part of the story is he's had more recently problems with diarrhea. So he was scoped and there were no amyloidomas. But I asked the pathologist to take the biopsies, which were negative, and do Congo red. And there was amyloid there.
In the bowel
And
wall itself.
in in the mucosa.
Okay.
Yeah,
Yep. Yeah. So then that is truly systemic in the sense, that
yeah,
it's infiltrating and all the rest and the diarrhea. And so, again, more often diarrhea is due to small bowel involvement because that's where a lot of the absorption goes on. And again, it can be all throughout the gastrointestinal tracts. So, given the fact that he has systemic disease and he needs to have therapy, if he's tolerating the Revlimid, then so be it. I have no problem with the person taking something they tolerate. It's a low dose and he's doing it. And so no objection. It's just typically not our very
yes,
first choice. And again, if this guy was diagnosed years ago, there probably wasn't daratumumab. And you might want to consider
right,
giving him
right.
daratumumab with that because he might get a deeper response. If he's progressing on the Revlimid, then that would be something to consider. Now, that said, there is Revlimid diarrhea, so the question here is this due to drug or is it due to disease? And so the best way to know that is you could just stop the drug for a little bit and see if the diarrhea gets better or not. If we decide it's due to the Revlimid, then you might want to just choose another therapy to have them in complete response, and a daratumumab would be a wonderful option. Another great option for patients is venetoclax if they have translocation 1114. So I don't know when he
Yeah,
had his
yeah.
bone marrow, if he had translocation 1114 as part of his FISH, these patients are exquisitely sensitive to BCL2 inhibition. And
Okay.
single agent, maybe with a touch of Dex, that's also another potential opportunity to treat a patient. But I'd just be careful with the Revlimid diarrhea because that is a real thing. We see that in our myeloma patients who are on Revlimid for a very long time. And you ask the question, how long is too long for Revlimid? And the answer is, I have no idea. The treatment today is indefinite until it either stops working or whatever. But we do know that there's a potential for secondary malignancy with Revlimid. And so more and more in the myeloma space, certainly there's look at patients who didn't have high risk cytogenetics or high risk FISH, and they get to an MRD negative status. Is there a role for perhaps stopping the Revlimid maintenance if patients have been doing well for a long time? But in your gentleman who still has a monoclonal protein, you would want to explore that this is indeed not due to drug, even though there's a little amyloid in his gut. And then if it is, and he hasn't had cardiac involvement or renal involvement or any other systemic stuff, you might even just want to watch him off of therapy. So you have all these wonderful other therapies you could use, but again, you might just observe him too is an option, especially if the light chains aren't very high.
So I will just make a little commentary. I remember as a fellow, which again is a long time ago, we were treating people with Alkeran and prednisone, and the outcomes were poor. And now, how exciting it is actually with four-drug regimen that so many patients go into remission. But that actually, in its own way, makes it even harder when people don't. So I want to ask about a patient who's sort of the opposite scenario, and it may just be an issue of time. This is a 69-year-old woman who presented with severe fatigue, and her creatinine was around 7. She was very anemic, and she had a large monoclonal spike. I think her total protein was about 11 grams, and about 6 grams was an M spike, an IgG kappa. So we did a bone marrow and it was just a ton of plasma cells. So she got Cybor D with daratumumab. And initially, everything was going well. We actually treated her in the hospital. Numbers came down very nicely. We're at about 6 weeks now, so we're not that far out, but she's really plateaued. The M spike is about 4 grams now. Her renal function improved to creatinine of about 4, and now is again leveled off over the course of the last 3 to 4 weeks. So, when do you start to get concerned about the rate of response and the pattern of response?
Yeah. Again, so in a myeloma patient, it's good that it's coming down. And I don't know if you had a kidney biopsy or not, but again, she still could get further improvement in terms of her overall renal function. You could certainly carefully introduce an IMiD, some Revlimid into here, using something like 5 milligrams a day or 10 milligrams a day or every other day kind of thing in addition to the daratumumab and the bortezomib and the dexamethasone, and see if that can make things happen if she truly has plateaued. You do want to get a response because you're trying to really preserve her kidneys. It's hard to know in these instances how acute versus how sort of subacute the renal failure was, because how much is there, hypertension and atherosclerotic stuff and other things that might not be reversible rather than the cast nephropathy that was due to the really high light chains. So again, if really there's no change between end of month 1 and end of month 2, you may want to just sort of see if you can introduce something additional, or you could try one more month and see. I don't know if you've sort of also, if you had cyclophosphamide and you had sort of dose adjusted it due to her renal failure, and then maybe increasing the dose of Cytoxan a little bit to account for the fact that her renal function is a little bit better. That's also something that could be considered if she's not having significant cytopenias related to it. So those are two options, I would say, in this setting.
So, let me add a piece of data that actually came back since her discharge. It says, and demonstrated, this is the fish, demonstrated a duplication of 1Q and a T1416 translocation.
Yeah. So she would be considered high risk myeloma,
Yeah.
given that she has the translocation and the plus 1Q. And so ideally, you would like to get her more intensive therapy in those patients. Thinking about transplant, stem cell
Yeah.
transplant is also important, though I would definitely not be excited about taking somebody with a creatinine of 3.5 or whatever it is
Right.
right at this time. If I remember correctly, I'd be afraid I'd put her into dialysis. So I'd really like to try to get her to a better place and perhaps give a little bit more time, but I would then want to possibly transplant her if you can get her to an EGFR of maybe 40 or so.
Mhm.
When somebody has an EGFR under 30, I get very anxious about taking them to stem cell transplant because the last thing you want to do is have them get septic or something and then end up on dialysis. But everybody has their own threshold for when they'll actually do a stem cell transplant. But if she can reverse, that would be great. And then transplant would be an option. But I also would want to have an IMiD. And then as far as maintenance, patients with higher risk disease tend to use dual therapy and for maintenance as opposed
Mhm.
to just single therapy. So again, the pathway, if you do induction, transplant for standard risk patients, it's either single agent lenalidomide or lenalidomide and DARA if you follow the
Yeah.
Perseus trial. But for patients with high risk disease, the question is what kind of doublet. Historically, we've used bortezomib and lenalidomide as kind of a maintenance strategy in the higher risk patients. It's unclear really if that is better than using the CD38 antibody and the Revlimid, I think, or lenalidomide. We have a lot yet to learn in that regard, but for sure, doublet maintenance if you were to get her to transplant. And if you weren't able to, again, I would do the quad with an IMiD gently introduced and then have her on definitely like long-term lenalidomide and DARA.
As I say, this is such a good opportunity, so I'm going to take advantage of it. A patient with myeloma, this is a man who's 65. Again, had a lot of pain, and at first his x-rays showed masses in the lung, and he actually was brought to my office by a member of the hospital staff saying, oh, he had lung cancer. Well, it turned out the biopsy did not show that. It was a rib-based lesion, and it was a plasmacytoma. So again, diagnosed with myeloma, and was on a 4-drug regimen and developed pneumonitis slash multifocal pneumonia. So it was difficult to tell. Some of the urine antigens did show strep, so this may have been a strep pneumonia. But how would you approach a case like that? And what's your experience in terms of side effects, either with the IMiDs or just side effects in general with treating these patients?
So, in terms of infection obviously is an important problem in myeloma patients, and certainly with our more immunosuppressive therapies, be it a PI, be it a CD38 antibody, be it bispecifics and CAR T. I mean, infection is all over. And so the question there is if we think it's an infectious cause, including if the patient, was the patient on PJP prophylaxis, could there be pneumocystis, all these other things. So
Right.
infection is always something you have to rule out aggressively. If we really don't have a pneumonia, and you said there was something about strep pneumoniae, so this one is sort of confounded by that we do actually have some kind of an infection. But if we didn't have infection and we just said, hey, is this some kind of interstitial pneumonitis related to either the IMiD or to the proteasome inhibitor, that's a trickier thing. And usually the steroids will be somewhat protective in that instance, but these things, there's no test to truly know. I mean, you can look, is there eosinophilia that might say that there's something going amiss there. It's not that common that we do lung biopsies to get to the source of it. So, withdrawing a therapy and seeing how things go, making sure there are steroids on board is important. And the DEX has a pretty long half-life. So if you're doing weekly DEX, that should somewhat cover, but sort of peeling away drug and seeing if that improves. But hopefully in this instance, it's just infectious and it'll get better. And we just hold therapy for a week or two, let the patient recover and see what happens.
Got it. All right. What other toxicities in your practice, which is obviously a very deep one in terms of amyloid and myeloma, but what are some of the other toxicities you've seen from the 4-drug regimen?
So infection obviously is a big one. The other with bortezomib, obviously that's infection as well. You want to have patients on acyclovir when you're using a proteasome inhibitor and or a CD38 antibody because you can get various herpetic breakouts, whether it's herpes zoster or herpes simplex. The other is neuropathy with bortezomib is something patients can get sort of bowel irritability, but usually with a weekly schedule. And a lot of the trials are 1, 4, 8, 11 kinds of schedules. But I think in practice, most of us go with weekly scheduling.
Yep.
Typically, with the once a week, if there's some bowel abnormality, it's like they either get a little bit the runs or they get a little bit of constipation. They can usually see a pattern. We can dissect a pattern and get them on either a little Imodium the day of,
Yes.
or more often it's a little bit of a laxative because they get not a true ileus, but a little bit of constipation. The other things that people can get, rarely lenalidomide can cause rash. That's something that's always been around. Rarely they can get an interstitial nephritis from that, but pretty uncommon. You have your obviously anemia that you can get. Usually the Revlimid or lenalidomide is the bigger instigator in that. Other cytopenias, long-term lenalidomide diarrhea that often is helped with a bile acid binder. So using Welchol can be very useful in that instance. There's the generalized fatigue that people might experience, and you dose adjust. The steroids are often the most toxic part of the regimen, and so working with that in terms of always having a PPI or at minimum a H2 blocker on board to protect against gastrointestinal distress, as well as then dealing with sleep. Some patients swear by taking the dexamethasone before bedtime. I always insist take it with some food or whatever and make sure you're on a PPI, but they say they sleep through the worst part and they actually get better rest, making sure they have a sleep aid available to them if they need it. Those are the very most common types of things. The typical quad that you use, the Revlimid based, like the myeloma based, the Cytoxan, there's a little bit more nausea. It's not so common to have the nausea with the IMID PI. I mean, it happens some, but boy, I prescribe a lot more antiemetics than patients actually use.
We were just talking about toxicities, and it brings up a related topic, which is, obviously there's some patients who are highly informed and they're reading the literature and they're up to date, but both literally and figuratively. But for the average patient who's not as medically savvy, how do you find you can make the disease understandable for them and also overcome some of the barriers they may be facing, whether it be depression, other mental health issues, social issues, which are very real for a lot of our patients?
Yeah, wow, that's a lot. Again, as you mentioned, patients are just so different. And I think the key is to meet them where they are. There are some individuals, they don't even want to know, and that's okay. They're willing to follow instructions and they just don't want to have a lot of information. Then there's sort of the patient who might want to know some and they go to an occasional webinar and things like that, or they'll ask questions. So there's definitely not one size that fits all for these individuals. And I think that you just have to, like I said, meet them where they are and give them as much education as they want. And for those that are really savvy and they're plopping an article down in front of you and saying, "Have you seen this yet?" And it's like, "Yeah, I have," or some, herbal. I mean, actually, I have the hardest time with the supplements and whatever. And I'm ignorant. And my thing is, if it's strong enough to help you, it's potentially strong enough to hurt you. But so I think that you just have to work with that. I forget how fortunate I am, actually. A lot of my patients are very compliant, and I'm not having to find bus fare, for them to get to
Yeah,
me and
yeah.
that kind of thing, which is just so hard. I can't even imagine what that's like in some instances. But the travails of if you're still working and missing work and trying to make things as convenient as they are, doing more video visits than sometimes I'd prefer. But again, just trying to meet the patient where they are. If they really can't come and it's for a visit, they're just on maintenance and they don't need a IV or those kinds of things, I think are very important.
Very good point. How about the patient who's unfortunately is really doing poorly? Let's say has had multiple lines of therapy and has really resistant disease. What are your strategies there?
Yeah,
I know it's sort of a broad
it
question,
is.
but it's one that we do face.
Yeah. And again, it's about meeting the patient where they are on some degree. There are clinical trials, and sometimes that's appropriate. Other times they're coming from a long distance and they can't be here 3 days a week or something if it's a phase one or something along those lines. Trying, using antidepressants as appropriate, using palliative care team shared responsibility or shared work is always going to be very important. Definitely working with symptoms. And if I don't have the bandwidth to be dealing with each and every one of those symptoms, working with palliative care can be really useful. And then in the right time and place, being very frank about, is hospice appropriate? I mean, it's a spectrum, right? It's always the art of balancing hope and realism for a patient.
We each sit with patients and probably have our own words that we use, but we don't get to sit with each other usually. What words do you use when you're really sitting with someone that you've known and you've been through this process? How do you share that news?
Yeah, I mean, many of them are savvy. They're always like, well, you always have something else for me. You always have something else.
Yes,
And
yes.
it's like, well, this time, as we're really coming down to running out of things, okay, well, we're really coming to having fewer and fewer options and sort of kind of leading them down that path. And then basically saying we can try this, we could try that. The likelihood is that it's not going to be very helpful, and I don't want the treatment to be worse than the disease. And at what point do we think about focusing on comfort and treating not just the disease, but you as a person? I mean, these are really just so hard, but it's amazing how patients often will kind of know what's going on too. It's not like something out of left field. And again, this is the art of medicine, right? There's not a
Yes, it is.
recipe, and it's going to be a little different for any given patient how that's going to play out. But it's never easy, obviously.
Absolutely. And thank you for sharing. So, as a generalist, let me ask you, what's the latest? I mean, obviously, we have the four drug regimen. What are some of the newer agents? What are the things that I and colleagues of mine should be looking at as whether to send patients to centers like yours or treat in the community? But what are some of the things we should be thinking about?
Absolutely. I'm a major advocate for clinical trials, and clinical trials don't have to always be for people that are in a desperate state, right? There are a lot of questions. Is program A better than program B? And so I think whenever possible, if there is a trial available for a patient, that should be considered if it can fit into their lifestyle and all the rest. A lot of the randomized trials, in truth, they come from Europe because that's where everybody goes on a trial. We do less well in the United States in that regard. But in terms of some of the really interesting and novel therapies, bispecific T cell engagers and antibodies are really so amazing at this point. We have two classes that are approved. We have the anti-BCMA drugs like clistomab and elrantamab, and then the other FDA-approved bispecific T-cell engager is talquetamab, which is a GPRC5D directed bispecific. And so those are really important in our armamentarium. And then, of course, CAR T. And right now we have sort of two brands, but they're both directed at BCMA. So there's the ide-cel and the cilta-cel. At this point, the cilta-cel looks like it has more durable responses, looking at 3-year PFS and things like that. So that's pretty exciting. Some of these CAR Ts are being moved. They had been for 4 prior lines, but now for cilta-cel, it's for 1 prior line, and for ide-cel, 2 prior lines. These novel therapies, however, as effective as they are, and how even though they each have had randomized trials showing that they produce deeper responses and longer responses than do your typical triplet that you might use in the relapse setting, especially for the cilta-cel, there's some neurotoxicity we're learning more about. So there's the immediate neurotoxicity, the ICANS and things while you're giving the drug, but then there's the other sort of more long-lasting kinds of toxicities that are being seen, like some Parkinsonianism, and there's sometimes a bowel issue with people get this sort of lymphoid infiltration in their gut and horrible diarrhea. Rare. These are rare things, definitely. Like Bell's palsies. We're learning better how to manage these things, sometimes using alkylator like Cytoxin to just sort of shut things down a little bit is things that are being explored and experimented with. And so, although, for example, cilta-cel is approved at first relapse, essentially, I'm a little bit of a wuss, and I tend to not think of it necessarily for first relapse, maybe second. I feel like our first thing is do no harm.
Correct.
There's
Yeah.
just nothing worse than, you're so well-meaning, and then all of a sudden, I guess, patient has this horrible side effect, and you just feel so responsible. But I think, again, the rates of these types of problems might be less when patients have less tumor burden and they're less beaten up. The secondary malignancies, there's just so much we're still learning, but it's amazingly exciting. And I think more and more in the community, the bispecifics are being incorporated into people's practices. The one caveat there is that, especially if you're using like anti-BCMA, so you're thinking of something like an ide-cel or a cilta-cel, which are the CAR T, as well as then the bispecific elrantamab or teclistamab. So far, it seems if you're using the same target, CAR T should go first if the patient is a candidate for it before the bispecific. Again, a lot to learn yet. It's all
Yes.
kind of a work in progress, but
Yeah.
it's so amazing and so exciting.
And I have to say, hearing you say that is very exciting, I think, for me and colleagues. Let me ask you briefly about the class of drugs that are antibodies to BCMA but carry a payload.
Yep.
Are those something that can be used in the community setting?
So belantamab had been approved as a single agent. There was no survival benefit. They took it away. But now there's been 2 trials, DREAM 7 and DREAM 8. And DREAM 7, it was basically using a triplet with either Dara with Velcade and Dex or belantamab Velcade Dex, and the belantamab outperformed. So any day now, we should be seeing belantamab back. And so that's a payload. That's belantamab mafodotin. Now, the one thing is you have the eye exams, which is, the toxicity of the belantamab is people can get different types of corneal issues and vision things. So you have to be having an eye exam every 3 weeks as you're dosing. Spreading out the frequency makes a difference, and that helps, and there's less eye toxicity. But the concern there is if you think that the patient may be a CAR T candidate and currently our only target is BCMA, I would say do the CAR T first, because that probably is going to give us the longer benefit, and then maybe you can down the road use the belantamab. But again, all we know is CAR T works less well if they've had prior BCMA. And so exactly how to sequence things is definitely a challenge.
So again, this is Dr. Ken Miller, and I have to say it's been a terrific episode. And personally, what a great opportunity to talk with one of the thought leaders about really tough cases and things that I'm seeing in my office that I think to myself, geez, what are some of the options? So with that in mind, I want to thank Dr. Angela Dispenseri, who is a consultant in the Division of Hematology and is the Serene M. and Francis C. Durling Professor of Medicine and of Laboratory Medicine and Pathology at Mayo Clinic in Rochester. Angela, thanks so much for being with us.
Oh, thank you for inviting me. It was really enjoyable.
And I want to thank all of you for listening to this terrific episode and for a listing of all of our healthcare professional continuing education activities, podcasts, and healthcare professional resources. Please visit lls.org/CE. And for any questions or to refer a patient to LLS, please contact our Information Resource Center by calling 800-955-4572. Information specialists provide personalized one-on-one support to help patients learn about their disease, treatment, financial, and support resources that are available in English and Spanish. LLS also provides other resources for patients, survivors, and their families that could be found at lls.org/support. And I encourage you to sign up to receive notification of future podcast episodes by subscribing at treatingbloodcancers.org. If you have suggestions for future podcasts, please click the feedback button on this episode page. And we look forward to you joining us on future episodes.
Thanks for listening to Treating Blood Cancers, the LLS podcast series for professionals. We can be found on iTunes and other podcatchers. You can subscribe at www.treatingbloodcancers.org and provide your suggestions for future topics. Visit our archives section on our website for other great podcasts. Be sure to rate and review us on iTunes. Keep up with LLS by following us on Twitter at LLSUSA and on Facebook at the Leukemia and Lymphoma Society. And access our professional continuing education activities by visiting lls.org/ce. Let's keep the conversation going. Until next time.